Worldwide, each year, 1.4 million children are born with congenital heart defects, and over 350,000 children acquire heart disease. You are taking care of them. The vision of the World University for Pediatric and Congenital Heart Surgery is that every healthcare professional, anywhere in the world, involved in the care of patients with pediatric and congenital heart disease should have access to ongoing education. Education, communication, mentoring, knowledge everywhere and for all. Imagine being part of it.
Hello, everybody. I am Jorge Cervantes from Mexico City, and it's my great pleasure, along with my co-chairs, Dr. Susan Botlo from Cape Town, South Africa, and Dr. Tjark Ebels from Netherlands, welcome to you to the World University for Pediatric and Congenital Heart Surgery Night Educational Webinar. So the subject for today is total anomalous pulmonary venous connection. During this 2.5-hour session, we are honored to have world expert international faculty members who will discuss important topics related to the anatomy, management, and surgery for total anomalous pulmonary venous connection. Each presentation will be approximately 8 minutes and 6 minutes reserved for questions from the audience. Please note that in order to maximize everyone's learning enjoyment of the educational material, the audience computer microphone will be muted. However, we encourage you to ask questions through your chat function on Zoom. To submit a question, open the chat function, select the moderator's name, type, and your question, and press the Enter key on your keyboard. Also, please note that the program is recorded and will be able on the World University website. Okay, so let's get started with the program, and Dr. Susan Botlo, president of our first speaker.
Thank you. My name is Susan Vosloo. I'm from Cape Town in South Africa. I'm really privileged to introduce the first speaker from Paris, France, Dr. Lucile Houyel. She'll be talking on embryology, anatomy, and classification of TAPVC.
Good morning. I'm Lucile Houyel from Necker Hospital in Paris, and I am very happy to contribute to this teaching course about total anomalous pulmonary venous connection. The definition of total anomalous pulmonary venous connection, according to the IPCC ICD-11 nomenclature, is a congenital cardiovascular malformation in which none of the pulmonary veins connect to the morphologically left atrium. There are two hypotheses concerning the development of the pulmonary vein: original connection to the sinus venosus, or direct original connection to the left atrial segment, This is assessed in the mouse by the expression of TBX18, which stents the systemic venous compartment, here the sinus venosus, and here the left superior caval vein, but not the common pulmonary vein. As you can see, all these elements are close to each other, which could explain the different interpretations. The primitive pulmonary vein originates from the mid-pharyngeal endothelial strand within the dorsal mesocardium, which is part of the posterior second heart field, with the development of the dorsal mesenchymal protrusion, also derived from the second posterior heart field. The pulmonary vein is shifted to the left. The myocardial sleeve, which surrounds the pulmonary veins, is added by differentiation of the primitive mesenchyme on the left side of the posterior second heart field, only after connection of the pulmonary vein to the left atrium. In TAPVC, the connection is absent, and the pulmonary veins don't have any myocardial sleeve, which explains the risk of postoperative obstruction. Before the connection of the pulmonary vein to the left atrium, the primitive lungs join in the splanchnic venous plexus, which becomes the systemic venous circulation. Then there is an intermediate period when the common pulmonary vein acquires a lumen, with drainage in both left atrium and systemic circulation, and when the pulmonary vein is progressively incorporated into the left atrium, the primitive communications will disappear. If the connection of the pulmonary vein to the left atrium does not occur, the pulmonary to systemic communications will persist to ensure the drainage of the lung. Here is a primitive systemic venous circulation, the cardinal veins, anterior and posterior, and the vitelline and umbilical veins, all joining the sinus venosus. Extracardiac TAPVC can be supracardiac when the pulmonary veins communicate by a vertical vein with the derivatives of the cardinal veins, namely the innominate, but also the superior caval vein, the azygos, and the coronary sinus, which is derived from the left cardinal anterior vein. Infracardiac TAPVC drains into the derivatives of the umbilical and vitelline veins, mostly the portal vein and the ductus venosus, also the inferior caval vein. Therefore, the only truly intracardiac TAPVC connects to the right atrium. This may result from an impaired atrial septation due to an abnormal leftward position of the atrial septum, or to a lack of development of the dorsal mesenchymal protrusion, leading to a rightward shift of the pulmonary veins. This type of TAPVC occurs mostly in heterotaxy and is thus considered a laterality defect. This was confirmed recently by a mouse lineage with deletion of a ciliary protein, which impairs the function of cilia in the posterior second heart field. These mice have, in addition to complete AVSD, TAPVC in the right atrium, and also DORV, which is highly suggestive of heterotaxy. And this is due to underdevelopment of dorsal mesocardium, posterior second heart field, and dorsal mesenchymal protrusion. Therefore, the current classification of TAPVC does not reflect accurately the embryology, as TAPVC to the coronary sinus is still classified as an intracardiac defect in IPCCC ICD-11 classification. In addition to these main three types, there is the mixed type with TAPVC at 2 or more levels. Mixed types have been classified into 3 categories. In type 1, each lung has its own pulmonary venous drainage. In type 2, there is isolated drainage of one pulmonary vein and the other 3 drain to a common site. In type 3, all combinations are possibly found, as you can see on this picture. You can see here an example of supracardiac TAPVC with all the pulmonary veins joining in a vertical vein, which is draining into the innominate vein and then the dilated superior caval vein. In the infracardiac type, all pulmonary veins join in this vertical vein in the portal venous system, with very often an obstruction within the liver here. This is an extracardiac TAPVC in the coronary sinus. You can see here the right atrium with the orifice of the superior caval vein and the dilated orifice of the coronary sinus. Here the probe is passed through the coronary sinus, and you can see that all the pulmonary veins join into it. If you look at the left atrium of this heart, the left atrium is small, as in all TAPVCs, because the pulmonary venous compartment has not incorporated into the left atrium. You can see here an intracardiac TAPVC in the right atrium in a fetus with heterotaxy, left bronchial and lung isomerism, polysplenia, but no isomerism of the pectinate muscles. And here you have the orifice of the superior caval vein, and just next to it, two separate orifices for the right and left pulmonary veins. And here a mixed type with three pulmonary veins communicating via this very stenotic vertical vein into the innominate vein, and isolated right upper pulmonary vein into the superior caval vein. In conclusion, embryology helps us, as always, to better understand the different anatomic forms of TAPVC, and should probably prompt us to review the definition of infracardiac type as TAPVC to the right atrium only. It also explains the frequent association with heterotaxy and with atrioventricular septal defect in this setting, as both are defects of the posterior second heart field and dorsal mesenchymal protrusion. It also explains the major complication of TAPVC repair, which is postoperative obstruction of pulmonary veins. Thank you for your attention.
Thank you. Can I hand over to Professor Ebels for questions?
Thank you, Lucile, for a fantastic presentation, as always. I haven't seen any questions yet, but one of the things that has occupied me for quite some while is this more or less disagreement between two schools of embryology. And you said something about that in one of your first slides. Can you expand on that a little bit, but in particular, how that impacts upon us surgeons in the treatment?
Exactly, there are two main attitudes or explanations for the embryology of the pulmonary veins, from the sinus venosus, which is a right atrial structure, or from the left atrium itself, from the left side, with the dorsal mesenchymal protrusion and the posterior second heart field. I don't know which hypothesis is right. I really don't know, because I'm not an embryologist. I've read a lot, all the papers, and it's difficult to make his own opinion, but the fact is that the tenets of the second hypothesis, by using techniques of marking the cells, it's already convincing. And finally, for the surgeons, I'm not sure that it has a huge impact. And as I concluded, all these structures are very close to each other. So it's really difficult to know.
Thank you. That is important to know for us as surgeons. There's another question I have for you. For me, at least, it's not always clear the difference between core triatriatum and total anomalous pulmonary venous drainage. sometimes the distinction, to me at least, is not very clear, and I'm at a loss during operation at what we're looking at. Can you explain to us what exactly the difference is? Or are there types that cannot be distinguished or, let's say, categorized in one of these two categories?
Yeah, it's not always easy to distinguish between the two. Cort striatum is a lack of incorporation of the common pulmonary vein into the left atrium. So it's a later defect. The pulmonary veins have begun to connect, but the floor of the common pulmonary vein has not disappeared. And which is important is that it can be kind of asymmetrical incorporation, so that you have a so-called membrane, but also two pulmonary veins into the left atrium and two pulmonary veins like not connected.
Okay, thank you. There's a question from the audience by Suvro Set, and the question is, what is a myocardial sleeve? How does absence of the myocardial sleeve increase the risk of obstruction?
A myocardial sleeve is some myocardial cells, stratification of cells which surrounds the vein and protects the vein from injury. So if the vein is by itself without any covering by myocardium, it's more fragile and more prone to stenosis, even before surgery.
Okay, so we'll see that later in this meeting when the stenosis comes into our discussion. There's one other question by Manuela Hebagigagana. Excuse me for, I cannot really pronounce his name very well. But the question is, does any embryological basis for recurrent obstruction after surgery? Oh, sorry, the question seems to stop prematurely. Do you wish to expand upon your question? Because it's not clear. Okay. Well, I think, thank you very much. We'll have to go on to the second presentation. Thank you very much, Lucile.
Thank you.
Thank you. I now welcome a real pioneer in pediatric cardiology, Norman Silverman. He is from Palo Alto, California in the US, and the topic is echo imaging and morphological comparison in TAPVC. Professor Silverman.
Thank you very much to the World University for providing me this opportunity to address you. I'm going to be discussing the echo morphological comparisons with totally anomalous pulmonary venous return. For a larger, a more extensive look at this, I have written a chapter in www.md1world.com on total anomalous pulmonary venous return and a commentary on the Congenital Heart Academy. The outline of this talk will talk about classification, will not talk about classification because Lucile Houyel has already presented that. I'm going to discuss the presentation in the fetus and its significance, and I will talk only about total anomalous pulmonary venous return presenting with obstructions and the potential for surgical correction based on the fetal echocardiographic findings, and finish off with a small note on mixed total veins. So I'll begin by talking about this paper by Dr. Gunnarsson, which talks in the Journal of Ultrasound in Medicine about the prenatal findings of totally anomalous pulmonary venous return. And as you can see, 4-chamber asymmetry, presence of pulmonary venous left atrial obstruction, confluence behind the left atrium, an additional recognition of a vertical vein, and abnormal Doppler signals are important in making the diagnosis. There were only 5 patients in this group in whom there were isolated pulmonary venous anomalies. And of course, this is the group that is going to be the most important for simple surgical assessment. Now, what is the significance is that total anomalous pulmonary venous return with obstruction, as everybody knows, is a surgical emergency, one of the few remaining surgical emergencies that cannot be palliated by means of prostaglandin, oxygen, and other pharmacological agents. But without prognosis, the risks are much, much lower. So the Doppler and color flow signals are valuable in making the diagnosis, and the signs of obstruction are critical in terms of management, because dilly-dallying with the surgical treatment can adversely affect the prognosis of these patients. And once these are identified and can be handled directly, that can be surgically treated immediately. And I bring to your attention this paper by some of the members, Jason Agrea, Constant, Gus Mavrudis, and Marshall Jacobs, on the direct triage of neonates with total pulmonary venous connection to the operating room when there was the presence of obstruction. So I think that this will probably improve the prognosis when it is more universally accepted. Now, it's very easy to recognize totally anomalous pulmonary venous return, which is remarkable because it is poorly recognized prenatally. And here, of course, you can see in this 4-chamber view the arrows indicating the presences of the left and right pulmonary veins. And in anomalous pulmonary venous return, there is no connection. You see the left atrium is bald, and there's this twig or stick-like structure, which is the total anomalous pulmonary venous return lying behind the atrium. There's also a symmetry between the chambers, with the right-sided chambers being large and the left-sided chambers being small. And there's also an atrial right to left shunt, of course, which is normal in utero. Here's just another few examples showing this twig-like precision behind the atrium. Here, the diagnosis is subordinate to the diagnosis of right isomerism, which was present in this patient with a complete AV canal. And of course, color flow will show you the position of the veins, and you can see that these are not draining to the atrium, but to a vertical vein going to the brachiocephalic veins. So pretty simply, in utero, here is a picture of a patient who actually has right isomerism with bilateral right bronchi, and the pulmonary veins are seen correcting to this characteristic way and draining down below the diaphragm into the porta hepatis. And of course, when we have this in utero and we have also the aorta, you can see these two structures with the flow both going away from the heart, down the descending aorta and down this anomalous vein, which, as you can see, is not connected to the back of the left atrium. And then when we look at this in a subcostal frontal plane, and you see the placenta here and a baby lying with its head on this side and the feet down here, you can see this vertical vein traveling down here. And I'll just orient this so that it functions. So here's the vertical vein traveling in this direction. And it's very simple to make this diagnosis in most of the cases. Now, total anomalous pulmonary venous return above the heart gives the characteristic snowman appearance. And here the vein is seen draining in front of the pulmonary trunk and gives this characteristic snowman appearance here without any evidence of obstruction within the vertical vein before it drains to the brachiocephalic and superior vena cava and right atrium. So that's really not much of a problem for us diagnostically after birth. The one that really is the surgical emergency is the one with the hemodynamic vice. And here you can see the pulmonary artery, the pulmonary trunk and left pulmonary artery, and the bronchus behind, and the vein draining in between these, and it gets pinched between this, creating the so-called hemodynamic vice between the bronchus and the pulmonary artery. And at that point in time, as you see the vein draining vertically, you can see that the velocity of change goes from red, which is low velocity, to turquoise and back to yellow as the vein is obstructed between the left pulmonary artery in front and the bronchus behind. And the Doppler signal is a continuous signal rather than the characteristic pulsatile pulmonary venous flow signal. Veins may drain anomalously, be obstructed at different sites. And here is a patient with an azygous vein draining into a superior vena cava. The azygous vein is large and receiving almost all, in fact, all of the pulmonary venous flow. And there's obstruction at the origin of the entrance to the superior vena cava. And here is the azygous vein draining into the superior vena cava above the right bronchovascular bundle. The most common and important one is this one, which unfortunately we see here as an autopsy specimen with the characteristic lack of a confluence of the vertical veins, identifying 4 veins draining through a vertical vein into the back of the liver, into the porta hepatis. And of course, that's an unfortunate thing. And the diagnosis can be made by angiography very beautifully, as you see here, or magnetic resonance imaging. But as these are surgical emergencies, echocardiography is the best bet. And here you can see an example of total veins from suprasternal notch imaging in a coronal plane going backwards and identifying again all of the pulmonary veins before it drains through a vertical vein and into the porta hepatis. And here I've used the superimposition of color, which is so valuable here, to identify these processes as it goes down through the vertical vein, through the diaphragm. And you can see the small left atrial appendage above and the pulmonary trunk and aorta, as well as we pass through this coronal plane in the neck. And of course, we can see the same features that we saw in utero with the vertical vein draining away from the heart in front of the descending aorta, and Doppler color flow imaging is indeed very valuable in looking at these particular images. We can more extensively look at the sites where obstruction may potentially occur at the diaphragm, in the veins, at the porta hepatis, in the liver, and finally at the site of the ductus venosus. And here are some subcostal sagittal images. There's the descending aorta. And here you see the vein draining into the porta hepatis through the hepatic vein, and then eventually into the left hepatic vein and into the inferior vena cava. And the right is a more extensive look at this large porta hepatis, the portal vein, and the ductus venosus draining into the left hepatic vein. And of course, the angiogram below, so the magnetic resonance angiogram below that showed these findings as well. And lastly, mixed total anomalous pulmonary venous return, one has to always guard echocardiographically as to account for all of the veins. And here is a specimen where there is a vertical vein draining to the superior vena cava, as well as a scimitar-like vein which drains to the inferior vena cava. And these can be recognized echocardiographically and by magnetic resonance. Here is a contrast into the superior vena cava. Here is the vertical vein draining around into the head and neck from a suprasternal view, and the subcostal view over here, which shows the vertical vein draining into the inferior vena cava. So mixed veins are also a problem, and all veins need to be accounted for in the echocardiographic process of making this diagnosis. So in conclusion, the bottom line is that in obstructed totally anomalous pulmonary venous return, recognition in utero is possible, and complete delineation permits surgery without the additional ancillary tests, and thereby improving the overall outcome and morbidity for these patients. Thank you very much.
Norman, again, thank you for a spectacular presentation. I was wondering at what age, gestational age, is such imaging possible?
Hi, Tjark. Thank you very much for that question. We can make this diagnosis with confidence, I think, from about 18 weeks of gestation onward. Of course, the older the fetus is, the easier it is to find this. But technically, we've looked at this from this point of view. It's a very easy diagnosis, actually. But it's one of the most frequently misdiagnoses. In a series that we did in utero, we found that the primary obstetrical perinatal groups had missed this in almost all the patients that were referred to us.
And what is your explanation for that paradox?
I think people don't look at the pulmonary veins. It's you know, they look at the 4 chambers and that's it. And so this has certainly become important now. I just wanted to say that as far as the problems are concerned, the total anomalous pulmonary venous return without AV septal defect or right isomerism is a totally different proposition from patients with isolated total anomalous pulmonary venous return. In the one, it's merely a secondary complication. In the other one, it's absolutely vital because in those patients, the only problem is the total veins, and those are the patients that need the immediate care with who can have a great prognosis if the veins are adequately repaired.
Do you think that there's any, if it's so easy, is there any other indication for alternate imaging modalities?
Well, of course there is, and I've shown you those, but the problem with the condition is that the obstruction gets worse and worse after birth. And so if you could make the diagnosis adequately with ultrasound, why would you subject a patient to a cardiac catheterization with the changes of blood volume and flow and worse pulmonary edema? And the same is true if you do CT scanning. And MRI, of course, requires the baby to be in the magnet for a very long time. And I think all of these things adversely affect the prognosis on the baby.
Well, thank you, Norman. We have to carry on due to the constraints in time. Thank you very much. And maybe I can conclude that the echocardiographers need more education. Is that fair?
Fetal echocardiographers, I don't think pediatric people have much of a problem.
Thank you very much, Norman.
Thank you.
The next topic is advanced imaging morphological comparisons. It's presented by Fahad Alhabshan. He is from Riyadh in Saudi Arabia. You may go
Hello,
ahead.
everybody. Hello, everybody, and thank you very much for giving me this chance to participate. I would like to thank the World University for this nice webinar. And my talk is about the advanced imaging, which probably will show you why echo is not enough. So if I can go to the next slide, I have nothing to disclose. Next. So the investigation for anomalous pulmonary venous drainage or connection includes the basic chest X-ray and echocardiography. And most of the cases of supracardiac total anomalous pulmonary venous connection can be diagnosed easily by echocardiography, and we send them to the OR at that stage. Cardiac catheterization nowadays is reserved for cases with where we expect that there is a stenosis in the vertical vein and the baby needs an intervention before going to the OR. Next. Nowadays, we have the CT angiography next and MRI, which has a lot of value in the assessment, especially in the complex cases, the difficult cases, and the infracardiac cases. And I'm going to show you multiple examples of those. Can we go next? So this is an example of the supracardiac TAPVC, where we can easily see all the veins. We should be able to see all the veins, count them, recognize each one of them, and look at the channel of this vertical vein. And then we can see the whole circulation very well by transthoracic echocardiography in small babies. If we have this clear vision, then we can go to the OR directly. Next. If this patient, you see, this is one of our old angiograms in a child who had a TAPVC, and you see this amount of contrast, which was used to inject only one vein, is enough next to show all of the veins. Next. It is enough to show all of the veins. You see, it is the same amount used to show all of the veins, and we can see them and recognize them and count them easily. We can get a nice three-dimensional reconstruction for the images, and our surgeons now are addicted to these, to see these three-dimensional reconstructions, because it gives them a nice spatial orientation of about the lesion. This child actually had a pulmonary atresia, and probably you can see the ductus supplying the pulmonary arteries. Next. This is another child that we had where the patient had situs inversus with an unbalanced AVSD, and you see the vertical vein is actually on the right side, and there is only one superior vena cava on the left side, and then we can see all of the veins are draining superior to the left superior vena cava. This patient, next, underwent cardiac catheterization as a pre-Glenn study, and you could see next, you could see that he had an angiogram, and then in the levo phase, we will be able to see that vertical channel draining to the left superior vena cava, but less than that amount of contrast is used in the CT angiography. Next. So these patients with complex or unusual presentation, we prefer to do advanced imaging to visualize these and give better spatial orientation to our surgeons. These are two examples of direct connection to the superior vena cava in our patients. The one image is from an MR angiogram, and the other one is from CT angiogram. Next. And then you can see the value of these, where you can recognize all of the veins, and you see this three-dimensional reconstruction that shows the huge vertical vein that is draining to a hugely dilated superior vena cava. These images, without doubt, would give you a better visualization where that vertical vein joins the superior vena cava in relation to the other structures, to the bronchus, to any other structures that is in the field, and how far is that from the left atrium before the surgeon operate on these. Next. So these are important to recognize. Yeah. So sometimes some patients especially with the complex cyanotic congenital heart disease, like this is one of our patients with right isomerism, you see the veins are normally connected to the posterior aspect of the heart, but because of the malalignment of the atrial septum, the veins are anomalously draining. So probably they are normally connected to the usual position, but they are normally draining to the right side with a severely dilated right side of the heart due to this anomalous drainage rather than junction. Next. These patients require advanced imaging also to see, because they may have systemic anomalous pulmonary venous connection. These are two examples of infracardiac total anomalous pulmonary venous drainage, one with the normal looking veins, the other one with anomalously draining small vertical vein to the lower part. These are difficult to track by transthoracic echocardiography. Next. That's why advanced imaging will be valuable to show all of the veins. And you see these veins, they come into a tree-like structure. There is no well-developed confluence that join these together. That's why the surgeon needs to see where is he going to incise, where is he going to connect these to the left atrium. Sometimes this vertical vein is stenosed at the level of the diaphragm or ductus venosus, but by nature, next, these are obstructed at the level of the liver. You see, this same child, additional value for this advanced imaging is to confirm the presence of of, we have seen that in the first talk in a nice specimen, I mean, in the previous talk by Professor Silverman, where he showed fetal imaging with a specimen showing a heterotaxic heart. You see this baby has a transverse liver, the NG tube is going to the right side next. And if you look at the bronchus, you see identical symmetrical bronchus to the right and left side. And these are showing the presence of right isomerism, right isomeric structure next. The other thing is that these, you look at the shape of the junction between these pulmonary veins, they look like a tree, and then the surgeon needs to track where to incise between these branches of the tree to be able to connect it to the left atrium. That's why these carry the highest risk of obstruction post-operatively. Next. You see, this is another example with a different looking tree. They don't look the same all the time. You see, every one of them looks different. Every one of them has different shape of confluence that is running behind the heart and then draining anomalously to the lower part of the body. Next. This is post-operative imaging for one of our children that was suspected to have an obstruction. You see, the surgeon usually ligate the vertical vein, but they don't obliterate it completely. This is the confluence behind the heart, which was enlarged by the surgeon. And that confluence has good connection of the pulmonary veins to the left atrium, and there is no obstruction. Next. So we can confirm that there is no obstruction postoperatively by this advanced imaging. The total anomalous pulmonary venous connection to the coronary sinus is another easy echo diagnosis. Next, because you can recognize all the veins, you can see them very well. Next, you can see them very well and you can count them. You can make sure that you can see all of the veins. Next, please. That are joining the coronary sinus, which is significantly dilated. The coronary sinus has usually the appearance of a whale tail. Next, which looks like the tail of a whale as the pulmonary veins join that. Next, please. The advanced imaging is reserved for those with unusual course of the coronary sinus, like this one, which is coming like in the middle of the heart. We were not sure if all of the veins are joining this coronary sinus, but actually they are if you look at the three-dimensional reconstruction. Next. The mixed type of total anomalous pulmonary venous connection are not easy to recognize by echocardiography, and then we need the advanced imaging to look at the different parts of the pulmonary veins, which one is draining where. Here we see left upper lobe draining to the innominate vein through a vertical vein, while the lower right and lower left, the whole right and lower left are draining to infrahepatic. Next. This is another case of a mixed type of total anomalous pulmonary venous connection where the whole right lung, you see the three veins are draining through a left-sided vertical vein to the innominate vein and then to the superior vena cava, while the whole left lung is draining infracardiac to the liver. So next, this kind of mixed type of total anomalous pulmonary venous connection, I don't think we can recognize everything by echocardiography. That's why advanced imaging is very important tool to recognize these. Next. This is an interesting case that we had of a truncus arteriosus with an anomalous pulmonary venous drainage. And then to repair this kind of complex anatomy, one of the advances that we can have next is to try to print these images in a three-dimensional fashion that can be given to the surgeon. The surgeon will hold it in his hand. If you can see on the black and white images, there is a big vein that's coming infrahepatic, which is here labeled in blue. And then you can label different structures of the heart, and then you can give it to the surgeon. He can look at it, he can recognize which one is coming which one is anterior, posterior, and then it will give a much better spatial orientation in the hand of the surgeon. Next. So these three-dimensional printing are very good. Here you can see the infrahepatic connection of that anomalous pulmonary vein. Next, and you can see it by the 3D imaging, and that will give a very good idea. The additional value for MRI also is the flow quantification. Next, where we can look at the veins, look at the anatomy, assess the volume, and also we can quantify the amount of shunt by calculating the QP to QS of these pulmonary veins. Next. So in conclusion, the anomalous pulmonary venous connection is not an easy diagnosis all the time to recognize. The supracardiac part is sometimes easy, the intracardiac to the coronary sinus. Other than that, in those, the echo is the main tool, but other than that, we need the advanced imaging next. Cardiac catheterization should be reserved only for those with where the intervention is expected to be of value next. The CT and MRI nowadays, they can add much better value in the recognition, the spatial orientation, and the proper anatomical evaluation for these patients. Thank you very much for your attention.
Thank you, Dr. Alhabshan, for a great talk and wonderful images. There is a question from the audience, and I shall read it to you. In some environments, there is a concern about radiation doses from CT. Could you please elaborate on that? And how does radiation from typical CT compare to typical angio?
Excellent. That's an excellent question, which is a big concern in children and small babies, especially those who are expected to require multiple investigations. Nowadays, we can do all of those advanced imaging. Actually, all of the images I showed you that we are doing for our children are done with extremely low dose of radiation. Now we are using what is called sub-millisievert dose of radiation. All of our children, without exception, all ages, all angiography, they are getting a full angiogram with a dose of between 1.5 to 3 ml per kilo of a contrast, which is enough. And that will give you a full image and with a dose of radiation that is less than 1 millisievert, less than 1 millisievert dose of radiation. Actually, in some babies, we have reached a dose that is extremely low to 0.1 of a millisievert. And now the unit that we use to assess the dose of radiation is called DLP, the direct length product. Nowadays, we are scanning with a single digit DLP, like DLP of 7, DLP of 9, DLP of 5. So we are bringing this with the recent advances in technology and the proper use of the machine and proper monitoring of that procedure. That's why an expert person needs to be there all the time. You can do it with an extremely low dose of radiation, which is a big concern in small babies. I would like to thank the person who asked this question.
There's a next question from the next speaker, actually, from Christopher Caldarone. He asks, please comment on preferred mode of investigation and frequency for surveillance to detect postoperative pulmonary vein stenosis.
Yeah, that's another good question from an expert surgeon. So I'm sure Chris recognizes how important it is for him before he goes to the OR that which type he is going to face. If we are interested in assessment of the anatomy alone in a critically sick child, then I will go for CT angiography because it will give you a beautiful delineation of everything. The scan time nowadays is less than 1 second also. The table does not move. With the new scanners, we have acquired one of the new scanners where the table does not move anymore. You scan while the baby is still. The scan time is less than 1 second. So even there is no need for a deep sedation or anesthesia. It is one dose of contrast and you get everything. If we get an older child with a mixed type of anomaly, we are not sure when to operate, and we are interested in calculating the shunt, knowing the hemodynamics, then I will go for MRI. But the downside of that is that it requires anesthesia and it takes longer in the scanner. For a simpler supracardiac cases, then I will go for echo. For the second part of his question, which one to go for the follow-up, I would prefer an MRI because usually the follow-up, it is not an emergency situation and we can do more extensive evaluation using MRI.
Thank you very much. We could go on for quite some time by looking at all the questions, but I think we need to go on due to the time schedule. Thank you very much, Dr. Alhabshan.
You're welcome.
We now move on to surgical management with a presentation on primary surgical repair techniques by Christopher Baird from Boston in the US.
thank you for inviting me and the opportunity to speak today. Let's see, do I have control? I have nothing to disclose related to this talk. So to start, I'd like to just give a list here in the last couple of weeks. This is the list of patients that have presented to Boston Children's with total anomalous pulmonary venous connection. And they presented in a number of different ways, and we managed them in a number of different ways. So I will just come back to this list after I've gone through the talk and walk through how we manage each of these patients. As has been just talked about in the prior few lectures, and I'm not going to talk about a whole lot, is that total anomalous pulmonary venous connection continues to have a low prenatal diagnosis rates. But of those patients that are found out there, heterotaxy syndrome is a common finding in these patients. And the reason it's more commonly found in these heterotaxy patients is because the vertical vein velocity has helped to identify them. So as I mentioned before, I'm not going to spend time on this as it's been talked about before, but it has allowed us to see patients earlier and have them at a larger center, referral center, to be cared for. So for considerations for neonatal TAPVR repair, first I'd like to talk about just a couple of concepts that I like to think about now anytime we're operating on pulmonary veins, whether it's a primary operation or a secondary operation for obstruction. We'll briefly go through the types and then the approaches, the more conventional sutured approach versus the sutureless type approach, and then the total anomalous pulmonary venous connection to the coronary sinus or the unroofing approach. There's some uniqueness to that, and then outcomes. So this is very important, I think, when we think about pulmonary veins. The fundamental anatomic consideration and the angulation and the compression that is upon the pulmonary veins affects how the flow patterns come about. And based on the flow patterns, if there's significant disturbance, we feel that's a nidus for obstruction. And so therefore, all the angulation considerations in the mediastinum of how the veins come in, and even the pericardial reflection, is critically important to how we surgically manage these patients from the beginning. Otherwise, you create angulations with different surgical technique that can actually cause problems and predispose you to have more obstruction in the end. So, for example, with infracardiac total anomalous pulmonary venous connection, you can have intrinsic narrowing. And so if you just connect at the confluence, then you still have turbulence. And then that's where you develop stenoses and pulmonary vein stenosis late. You can also have angulation at the pericardial reflection. Is this tethered? For example, commonly in infradiaphragmatic veins, the right lower pulmonary vein has a long obscure course that comes across directly medial. And then the confluence diameter of how large you make that. If the confluence diameter is this large and you compare it to the orifice of these veins, it's not near enough. So, and sometimes because we're limited on how big we can make this confluence, we're setting ourselves up for flow turbulence and disturbances. This is an example, and I'll come back to later, that I think is really important and highlights the fact that the way the veins present, and what they're showing here, patients that present with this so-called antler configuration, if you will, are at significantly more risk for pulmonary venous obstruction. And so I think if we can recognize this preoperatively, it may guide us on the type of technique we'd like to use. And we'll talk a bit about that later. And maybe this is a type of patient we'd like to use a mixed technique with some sutured repair and some sutureless repair. This is the different types of mixed type of vein disease. And these are the type of patients I think we should think about alternative solutions for, because these are the highest risk patients that develop obstruction and mortality. And so we have to think a little bit outside the box how to manage these patients. So with regards to the surgical approach, as we talked about, we have the conventional suture type repair. And then we have the sutureless type repair that we suture up on the pericardial edge. And then what we don't show here is the combined approach, say when we did half of it with a sutureless type repair and the other half with a suture type repair, which is not infrequently done in, say, the mixed type of disease. This is just the standard posterior approach with the surgeon off to the left of the screen here, the vertical vein. You open up the confluence and do a posterior anastomosis in a typical type fashion. This is the anterior approach, and it's my preferred approach for most all types of vein disease because it gives you a more direct anterior approach that doesn't distort the heart when you're sewing the vein in. So it allows you to line up the confluence in more the native position better. So I find this quite critical when we're lining up the confluence. If you don't do it this way, you need to mark the veins on the back of the heart so you know exactly where to place them. This is a modified superior septal approach. There's a number of modifications of this where you can divide the aorta. In fact, you can divide the pulmonary artery. You can divide both if you're really having difficult exposure to get to this area for supracardiac type of repair. And then the total anomalous pulmonary venous connection to the coronary sinus. This is a important part of the operation. Is not just dividing the entrance to the coronary sinus, but you have to go all the way down throughout the entire coronary sinus, divide it, and actually see the orify of the pulmonary veins. I have to say we get a fair number of referrals with this type of disease because the pulmonary veins were never completely unroofed and you left an obstruction. Quick question about circulatory arrest to use or not to use. This is a manuscript that just points out that you don't really have to use circulatory arrest to have good outcomes. I routinely now don't use circulatory arrest. We use a Yazergill type clip to control the return, and then we just have to use mild hypothermia and thus don't have the effects of full circulatory arrest. I'm not going to talk a lot about this. Echocardiography has been discussed, but we routinely use echocardiography postoperatively in the operating room to help identify if there's any turbulence or any velocities that should raise concerns. And we will go back at that setting if there's any question to readjust the anastomosis if necessary. But I think this is a critical piece to identify any problems. And we preferentially use epicardial so we don't distort the confluence posteriorly with the TE probe. I've seen it well more than once that the TE probe actually causes confluence compression and causes a problem either from the beginning of the case or at the end of the case. Now, briefly, just to run through some outcomes quickly. This is outcomes circulation, 377 patients over 60 years. Obviously, mortality decreased over time as surgical technique and ICU management improved, as well as the diagnostics. Mortality is the highest and not unexpected, the youngest and smallest patients, the mixed type. And you'll see this in the next several studies. They basically all say that the mixed type is the highest risk. Pre-op obstruction is higher risk and unfavorable anatomic characteristics. 768 patients over 10 years, study out of China. Risk factors, again, younger age, mixed type. They also found infracardiac type more so than supracardiac, and again, preoperative obstruction. So some large studies here that are showing some common findings. 256 patients over 35 years, follow-up of 10 years. What this is showing, 20-year survival is 85%. If they don't develop obstruction, they have 92% survival at 20 years. If they do develop it, obviously this is the pulmonary vein stenosis problem, and you have only 40% survival. Predictors, again, younger age, lower weight in an emergency case predicts worse outcomes. This is comparing non-infracardiac versus infracardiac. And again, this leads towards kind of the mixed type of vein disease, having a longer post-op course, more complications, increased mortality, and again, increased post-operative obstruction. Outcomes, and specifically looking at infracardiac total anomalous pulmonary venous connection, sutureless technique, and I'm going to talk about that in a little more detail comparing sutureless versus non-sutureless in just a minute. So in infracardiac, this study showed less postoperative obstruction risk with that. And then this is the study that actually looked at that antler configuration and showed very specifically with this configuration preoperatively, there's a higher risk of postoperative pulmonary vein obstruction. That suggests we need to probably do something different with these type of patients. So consider alternative solutions, maybe stenting the vertical vein pre-op, allowing them to get bigger, maybe doing a mixed type approach with a sutureless and sutured repair. But this type of configuration, we probably need to think about a little differently. This paper specifically brings out heterotaxy and single ventricle along with mixed as increased risk factors. So again, how do we think about these patients differently? In our list of patients there, we treated these a little bit different because we knew that they were higher risk. And then mild preoperative obstruction, again, is a risk factor. This is just transplant-free survival without obstruction. So you can see still a number of these patients develop obstruction postoperatively. Again, this is studied just looking at a 30-year experience of the mixed type. They had a higher mortality, although once they get out to 1 year, the outcomes equalize. Heterotaxy, this is one out of Boston 15 or so years ago. Higher mortality rates, again, with heterotaxy. And again, obstruction is more common with mixed and intracardiac. So you're seeing a theme there. This is coexisting cardiac lesion. This kind of goes back to the single ventricle patients or the significant associated cardiac lesion. There's a very high mortality rate. So again, let's think about alternative strategies and how we're going to manage these patients instead of just taking them to the operating room and so-called doing a vein anastomosis. Outcomes, I found this interesting. This was LV size, remained normal after simple vein repair. But even at 1 year, the left ventricular end diastolic pressure remains high. And this correlated linearly with age at time of repair. So almost regardless of these patients that present with the smaller LV and they're repaired early, they have still some effect at 1 year with regards to their left ventricular end diastolic pressure. And this is a study that just out of Texas that just shows that likely higher volume centers are associated with lower mortality, particularly with regards to total anomalous pulmonary vein repair. With regards to outcomes of sutureless versus non-sutureless, this is a large meta-analysis. There's no survival difference between these techniques that they have shown, although the sutureless technique showed less reoperations and less postoperative vein obstruction. This, again, it's simple total anomalous pulmonary venous return out of Toronto. Regardless of the increased preoperative risk, there was no difference in death or reoperation between sutureless and non-sutureless. And this specifically is looking at supracardiac repair, sutureless versus non-sutureless, and there were no differences between the sutureless versus non-sutureless techniques. This is mixed here. And so with mixed TAPVR, there was no difference in mortality or reintervention. However, as you can see in the curves here, there was a trend towards improved survival and reintervention. So this begins to look at what I'm talking about. Maybe we use a different type of technique for different types of vein disease. So there's not one surgery for all types of vein disease. So with regards to our patient, what was our approach in the last couple of weeks? This patient had heterotaxy, a number of comorbidities, omphalocele, small cerebellum, left dominant canal, essentially a single ventricle. We're currently observing this patient. It's being managed well. We expect to have to intervene soon, but if we can get out a couple of months, our outcomes will be better. This is another patient, heterotaxy, bilateral SVCs, subpulmonary VSD, subpulmonary stenosis. We had sent to the ward, readmitted to the ICU on day of life 5, and we stented the vertical vein. So now this patient is back out on the ward doing well, and we plan to bring them back for more definitive procedure in the next few months. Consider alternative solutions for these patients. Just don't take them to the operating room. This is an example of that patient we just talked about, where we took and stented the vertical vein as it came into the right SVC there. And then with regards to the other patients, cardiac type of total anomalous pulmonary venous connection, heterotaxy, this is the one I just mentioned. We're watching an infracardiac obstructed. As you can see, we took to the operating room within 24 hours. This is another one, supracardiac obstructed. We took to the operating room within 24 hours. This is a supracardiac that had progressive obstruction. We'd sent to the ward and ended up taking it a week. This is the stenting of the vertical vein of a supracardiac with heterotaxy, the one I just discussed. This was a really sick patient that presented at 1.5 kilos, obstructed with esophageal atresia, TEF, prematurity, and difficulty ventilating. This one we took in the middle of the night, stented the intracardiac vein, and then prior to ligating the fistula and placing the G-tube. And then this one is a supracardiac unobstructed that we're watching. So in conclusion, prenatal diagnosis may lead to improved survival. Total anomalous pulmonary venous connection with the mixed type, it's associated with higher morbidity and mortality. So let's consider alternative, either surgical solutions or management options. Associated heterotaxy, the same, higher morbidity and mortality. With regards to surgical technique, there's really no demonstrated difference in sutureless versus non-sutureless for simple type repairs. Consider sutureless for more complex or mixed type of repairs, and higher volume centers may have improved outcomes. Thank you.
Thank you, Christopher, for a comprehensive presentation with wonderful information. Unfortunately, time is up, and we have a time constraint as to the length of this webinar. So I'm afraid we'll have to carry on to the next speaker.
Okay.
I'm now introducing Christopher Caldarone. He is from Houston, USA, and the topic is management of recurrent obstruction.
Talk about management of post-repair. Hello, it's a pleasure to be involved in this webinar exploring total anomalous pulmonary venous connection. I've been asked to talk about management of post-repair pulmonary vein stenosis. I'll start with a case report. This is a 2-month-old with supracardiac total anomalous pulmonary venous connection, repaired at an outside hospital, who was noted to have postoperative pulmonary hypertension. A CT scan was obtained, and these are representative axial images showing the right-sided pulmonary veins entering the left atrium, and this is the left-sided pulmonary veins, which appear to be unobstructed. You'll notice there's a very small leftward anastomosis that was constructed here, and this is quite typical of many of the referrals that we see. Over here you see a residual atrium and posterior pericardial wall that is essentially created a long pathway for the right pulmonary veins to enter the left atrium, and this is indeed where we found on catheterization a significant gradient. We repaired this lesion using a sutureless technique. Basically, we made a right atrial incision, we opened the atrial septum, and identified the small leftward pulmonary venous anastomosis. We then resected all tissues rightwards, including the posterior wall of the left atrium and the anterior wall of the right-sided pulmonary veins. The right-sided pulmonary vein incision was extended into the branches, and then this reconstruction was created by sewing the atrium to the pericardium, creating a new atrial septum in a more anterior location, and closing the right atrium. Shown in cross-section here, this is the right-sided pulmonary vein flow path through the stenotic anastomosis. This is the pleura. This is the right atrium and the atrial septum. Basically, the entire cross-hatched area is resected, and then the reconstruction is accomplished by sewing the pericardium to the right edge of the right atrium and reconstructing the atrial septum more anteriorly, creating an unobstructed flow path for the right pulmonary veins into the left atrium. The best way to treat post-repair pulmonary vein stenosis is to prevent it. Effectively, that means create a large anastomosis, and there's some reluctance among surgeons to resect rightwards during total anomalous pulmonary venous drainage repairs. There's reluctance to incise into the branches, especially when the confluence is small, And that reluctance is because there's potential for suture line distortion. The sutureless repair diminishes need for perfect approximation between the pulmonary veins and the suture line because the suture line is between the atrium and the pericardium. There's greater tolerance for complex geometry, especially in patients with small confluence or complex geometry at the end of an incision into the branch pulmonary veins. And of course, there's no need for circulatory arrest. If you have post-repair pulmonary vein stenosis, which 10 to 15% of the patients tend to have, or you have congenital pulmonary vein stenosis, 5-year survival is roughly 55%. Returning to our patient, we have an aggressive surveillance protocol after repairs of post-repair pulmonary vein stenosis. This was planned for 1 month, but the patient was lost to follow-up and didn't have their cath until 3 months. We found the right pulmonary veins were widely patent, and we are quite pleased with this aspect of the result. The left pulmonary veins, however, delivered a surprise. There was no disease when I operated the first time. Nevertheless, on postoperative surveillance, we found that the left upper pulmonary vein was completely atretic and the left lower pulmonary vein had severe stenosis, a cautionary tale on the importance of postoperative surveillance. It's clear that postoperative surveillance is very important because the disease can progress clinically silently. One of our fellows, Mauro Larito, examined patients with post-repair pulmonary vein stenosis, specifically exploring the relationship between the upstream pulmonary vein diameters and the downstream pulmonary vein diameters at the left atrial junction. He found something that looks like this. This is survival on the vertical axis and the upstream combined diameter on the horizontal axis. Each one of these bars here shows the combined downstream pulmonary vein diameter. And what you see is survival doesn't really change very much depending on different downstream combined pulmonary vein surface areas. The upstream pulmonary vein surface area, however, is important. There seems to be an inflection point around 270 here, which isn't so important. The important point is that what you want to do is operate here where the pulmonary veins upstream are still quite big. If you wait until here where the pulmonary vein upstream diameters are very small, you have a very poor prognosis. And this underscores the importance of surveillance. I think any patient having post-repair pulmonary vein stenosis repaired needs a clinical surveillance protocol in place to detect recurrence early. It progresses silently, indeed, as it did in the patient I described to you. So I recommend axial imaging at 1 month. In combined surgical and cath-based therapy, which seems to be the way we're going to manage post-repair pulmonary vein stenosis, survival, as I said, is about 50 to 60% at 3 years. This is some data from Boston, and the reason I'm showing you this is that in-stent restenosis is common, about 50% at 1 year, but there seems to be a critical diameter, a diameter of greater than 7 or 8 millimeters at which the probability of reintervention goes down. In other words, it appears that the disease begins to burn itself out, and that's very important in managing these patients. Dr. Kalfa looked at post-repair pulmonary vein stenosis in a large multi-center trial, including 75 patients across Europe and North America, and examined the impact of the sutureless repair for this lesion. Dr. Kalfa found that the sutureless repair was associated with better survival than patients who were treated with the non-sutureless technique. A severity score was also introduced in this manuscript, and after repair, the patients with the sutureless repair tended to have better preservation of their repair, in other words, less progression of severity. That is shown here in this table, where patients having sutureless repairs had less recurrence or persistence of pulmonary vein stenosis, had less pulmonary vein reinterventions and less pulmonary vein reinterventions or mortality when compared to the non-sutureless population. This is a description of our proactive management cycle. Basically, any patient entering this cycle who is going to require surgery or cath, what we want to do is institute a surveillance protocol with 1, 6, or 12-month follow-up. If they recur, then they enter the cycle, which basically means that a cycle length of about every 1 to 3 months, they're going to have either a cath intervention or surgery, subsequent reimaging, consideration of medical therapy, and round until they leave this cycle. The only way to leave this cycle is if they have stabilization or a cure. They are deemed futile, in which case no further intervention is necessary, or they go on to transplant. If you have to treat post-repair pulmonary vein stenosis, again, there's an increasing body of evidence supporting the use of a sutureless technique, most suitable for anastomotic stenosis with large upstream veins. But you need to anticipate restenosis. 1 month surveillance, I think, is mandatory, a low threshold for a return to the cath lab, and recurrences should be treated by a team focusing on medical and interventional therapy, as well as occasional surgical re-repair. Thank you.
Thank you, Christopher, for a great presentation. I think you made a lot of things clear, and there's a question from the audience from Jaroslav Mikichak, and his question is, what factors besides severe upstream stenosis or atresia would preclude reoperation or reoperation?
Dr. Mikichak, it's nice to hear from you. I think the small upstream pulmonary veins by far is the biggest indicator that a surgical reintervention is unlikely to be successful. Although we talked about reoperating again, frankly, at Texas Children's Hospital, we're far more often going to be in the cath lab to try and rehabilitate pulmonary veins in that reoperative setting. Also, I think, medical management, we're learning a lot about in terms of how to manage this. Our strategy is basically to try to get the pulmonary veins decompressed at the left atrial junction and then institute pulmonary vasodilator and pulmonary vascular remodeling therapies during that window of opportunity that we have until restenosis occurs. And then they're back in the cath lab again and redilating very aggressively.
There's a second question from Akif Mohideen. What is the pathological basis of restenosis in TAPVC repair, or is it iatrogenic?
I think there's an element of both. I think there's a biologic predisposition to have this myeloproliferative response at the site of anastomosis, and that is some fundamental biology of the pulmonary veins and their endothelia themselves. But on top of it, the problems we have is surgeons who create a small anastomosis. And as I outlined, they create a small anastomosis because we're reluctant to extend these incisions into the pulmonary veins. Furthermore, as nicely shown in one of the earlier presentations, surgeons often don't have CT imaging to fully define what the anatomy actually is. And I think that gives the surgeon a huge advantage to ensure that all the pulmonary veins are unobstructed. If you're not sure where the pulmonary veins are, you made your task a lot harder in the operating room. So not going in blind is another important factor. The third factor is this kind of suture line distortion that can occur anytime you're sewing a low pressure anastomosis. We all know when you sew a superior vena cava together, it's prone to stenosis. It's a low pressure system, and the slightest bit of tethering of the suture can create a stenosis. Similar with pulmonary veins, the slightest bit of tethering by the sutures as you traverse a complex bit of pulmonary vein geometry predisposes to pulmonary vein stenosis. So the bottom line is you have a biologic predisposition. We have a history of not having full information before we go into repair. We have a reluctance to extend into the pulmonary veins. And there's the simple technical problem of tethering it at the suture line.
Thank you, Chris. We have to go on to the next presentation. Thank you very much for a wonderful talk.
The next presentation is on the role of interventional cardiology. It's presented by Alejandro Peirone from Cordoba in Argentina.
Good morning. Thank you very much for this opportunity to be part of this World University. Thank you especially to Dr. Tjark, Cristo, and Ignacio Juaneda, who is our regional delegate, and Dr. Ebels. In the next 8 minutes, I will try to explain the role of interventional cardiology in total pulmonary venous connection. I don't have any. Next, please. I don't have any conflict of interest. TAPVC is a rare cardiac malformation. We know that remains with the lowest prenatal detection rate. The obstructed types are found in 25 to 50% of patients. 10% of patients require diagnostic cardiac cath prior to repair. You know, the primary surgical repair is the gold standard. However, sometimes primary transcatheter palliation may be necessary. You know also that there are 3 main important roles of interventional cardiology. One is in the diagnosis. The second is the initial palliation as a bailout intervention, and also as a management of pulmonary vein obstruction after surgical repair. The diagnosis, you know, that this has been shown in this seminar, that is typically made by color Doppler echocardiography. CT and MRI also are valuable for providing anatomic information as a pre-surgical planning and also post-surgical follow-up. But almost 10% of the patient needs and undergo to diagnostic cardiac catheterization, and is most common this technique in the mixed type TAPVC. You know also that the Doppler echocardiography is very easily performed, is user-friendly. And you see beautiful, very straightforward cases like some supracardiac TPV and also infracardiac with some portal vein obstruction. And also you see some, next please. So you see from there, you see some CT with infracardiac type . So with infracardiac type to the portal system, and it's beautifully seen with CT angio, and also you can see some MRIs with the supracardiac type that are beautifully seen, that was already explained. But you have some time the need of cardiac catheterization, as in these 2 cases that we have with a supracardiac with a stenotic area just in the anatomic base, where the left bronchi and the left pulmonary artery go through there, the collector, and you see the obstruction there, and also some infracardiac tie to the portal system, where you see the entrance of all the conference down to the liver. So those are very nice images where you can diagnose and show to your surgeon prior to the surgical repair. But our initial interventional options typically occur with obstructive type in the setting of some other comorbid condition or poor clinical status like prematurity, low birth weight, multi-system organ dysfunction, and also multiple congenital anomalies. And also, sometimes in this part of the world, it's important to take into consideration that surgery is deemed high risk or not possible, or maybe available for those very sick patients in that specific time. So what we have done and have published is that some bailout procedures to help the patient to stabilize before going for surgery. The first is balloon atrial septostomy. All the systemic cardiac output must progress through the interatrial septum, and sometimes it's restricted, that we need to improve that that communication before going for surgery. And the second is stent placement to relieve obstruction to pulmonary venous return, to reduce the pulmonary venous hypertension, and also to allow for stabilization of the patient prior to surgical repair, as we have done in this couple of patients where the anatomic bite was obstructed. We implanted a stent retrograde, and you see how the diameter improved and the patient gets better before going for the surgery. Or maybe this other patient that had some TAPVC to the azygos vein and was obstructed, and then with a superior access, we were able to implant some other stent, and the patient improved to get surgery in better conditions. So these are procedures that we do as a bailout procedures to help the surgical team to get a better results. And also, we have some other role, that is the third role that I want to mention, the transcatheter option for the PVO after initial surgical repair. Has been said that the majority of transcatheter technique has been developed for this type of obstruction post-surgical repair. The incidence vary from 5 to 18%. The preoperative pulmonary vein hypoplasia or stenosis is a strong risk factor for the development of post-operative disease, as just Chris mentioned, and the need for pulmonary vein reintervention following initial repair is higher in the heterotaxis syndrome that has been mentioned. And also the mechanism that somebody in the chat asked is believed to be for neo-intimal proliferation, intrinsic pulmonary vein hypoplasia, and also inadequate surgical relief of obstruction. This can rapidly progress, and histological studies suggest that myofibroblast proliferation is mainly responsible for this lesion. So there are some techniques that we can apply to this disease, as the group of Boston has the initiative for this kind of interventions, comparing some conventional balloon dilation and cutting balloon angioplasty in this type of patient. Both were some conventional balloon and also cutting balloon were effective at decreasing the gradient and increasing the lumen size of the vessel. The reintervention was very common in both treatment, and both methods provided limited benefit, and neither was curative. So they advanced, and also they mentioned regarding the stent implantation for the treatment of congenital and post-operative pulmonary vein stenosis. Acute relief was reached in both groups with stent placement. Larger stent lumen size and implantation was associated with a longer stent patency, like Chris mentioned, and they have also low risk of reintervention. But reintervention is very common with limited long benefit. And you see here that pre-balloon dilation and also pre-stent, the increase of lumen size is modest, and then with stent placement is much better, including bare metal stent, drug-eluting stent, and also covered stent. And here that was shown by Chris also. The survival rate was similar in both groups, and also the diameter was very important. Above 7 millimeters, you see that the reintervention rate is low than if you put stent below that size. Also, we see that this very interesting group from Japan that published this nice paper that is actually a very good review, that the improvement on survival and stent patency, if you implant stents at a larger diameter, confirming that the Boston group said. The Boston group mentioned 7 millimeters, the group of Japan above 8 millimeters, but this is a good diameter size to decrease the rate of reintervention. An early and aggressive reintervention after stenting is also mandatory to obtain good outcomes. As they mentioned here, you see there are no significant difference between the stent group and the balloon group. The overall outcomes are similar, but improve diameters. Also, no difference between bare metal and drug elusive stent because they were just small sample size. But here you see that if you implant a stent above 8 millimeters in diameter, comparing with less than that, you see that the reintervention rate, or the freedom from reintervention, is much less if you put a larger size stent. And also, you see that the probability of free from reintervention with pulmonary vein stenting, and you see here how the reintervention rate is regarding time is really a high reintervention rate, but they have postulated the hybrid pulmonary vein stenting, that this is a way to solve some kind of problem regarding multiple vein stenosis. And also, if you have delineated perfectly where the stenosis are, you can go with your surgeon, although this involves a cardiopulmonary bypass, but you can implant stents. The preferred method of placement in this group in Japan that we think that is a good option is a hybrid pulmonary vein stenting, where you can implant the stent, your surgeon can cut the strut into that protrude into the atrium, and you can secure with some stitches the stent, and maybe this is the way to go in order to implant larger size stent to prevent restenosis and reintervention. And what are the future direction that we as interventional cardiology can offer to this disease that is really a problem? The hybrid approach is one way to deal with it. Larger stent, as I mentioned, above 7 or 8 millimeters is also a good option. Aggressive in-stent balloon redilation, we can use now that there are not a validated data so far, but use a drug-coated balloons for in-stent redilation, and some chemotherapy associated to interventional techniques to prevent restenosis, like vincristine, methotrexate, some other drugs that can help with that reintervention. So, as a conclusion, I think that pulmonary vein stenosis is a life-threatening and challenging condition. Interventional cardiology plays a role in 3 main directions: diagnosis, bailout, palliation, and also therapeutic option after surgical repair. Outcomes, acute outcomes after initial treatment are good, are satisfactory, although the need for intervention is the rule. So further investigation for the development of novel treatment of pulmonary vein stenosis, I think, needs to be conducted. Thank you very much.
Thank you, Dr. Peirone, for a comprehensive presentation. I think we're all wondering, and there's some questions about that, what actually is the evidence for the use of drug-eluting stents in pulmonary veins in children?
Yes, no, there is no evidence. There are some studies regarding extrapolating things about, although the etiology of the stenosis seems to be myofibroblastic proliferation and endothelization, and extrapolating some experience from coronary arteries and also from stenting ductus arteriosus. This is the way to try to see if drug-eluting stent can decrease the neo-intimal proliferation. So need try to see if they decrease the restenosis and the needs for reintervention. So it's extrapolation experience from coronary arteries and from PDA stenting that maybe the etiology is not similar, but is a way to decrease, to see if we can decrease the rate of reintervention.
Well, if drug-eluting stents were actually beneficial, then by now we should know it, because they have been around for a long time. So isn't it so that it's pretty unlikely that it is beneficial?
Yes, if you see the data, there are some studies, but with small number of cases, trying to prove that bare metal stent is less effective than drug eluting stent. The tendency seems to be the case, but there's no definite data to confirm that that appreciation.
Well, thank you very much for this presentation. We have to carry on. Thank you again.
We're now moving to more complicated cases where the TAPVC is combined with functionally single ventricle hearts. It's presented by Shingo Kasahara from Japan, Okayama.
Ladies and gentlemen, thank you very much for giving me a good opportunity for presenting at this webinar. I'm quite honored to be here. Today, I'd like to talk about a treatment strategy for single ventricle with total anomalous pulmonary venous return. Among them, I will focus on TAPVC repair in right isomerism. No disclosure. TAPVC repair is still challenging in a patient with right isomerism and functional single ventricle. STS database revealed high mortality in such patients. Younger age at TAPVC repair is also known to be associated with higher mortality. Previously, we reported that combined TAPVC in Peirone syndrome was high incidence of mortality, especially short-term result was significant downslope. It shows that pulmonary venous obstruction occurs relatively frequently in this group. Although it was still in a stage of not being fully considered, other interesting evaluation was showed that the age at TAPVC repairers highly related the survival rate. In our new strategy, primary draining stenting was applied to the patient with perioperative pulmonary venous obstruction to delay TAPVC repair. Since 2009, it was performed in a case with right isomerism and function single ventricle when stenting was anatomically and physiologically feasible. TAPVC repair was delayed as long as possible until patients had stenosis or required other surgical interventions. This study investigated the efficacy and the problem of the delayed strategy of TAPVC repair. We retrospectively reviewed all patients with underwent operative repair of TAPVC with right atrial isomerism and function single ventricle at our institution between January 2019 and June 2020. We focused on the patient who needed surgical or catheter intervention in their neonatal period. Of the 50 patients with underwent operative repair of TAPVC with right isomerism and functional single ventricle, 29 consecutive patients with severe obstruction in a course of draining vein and needed surgical or catheter interventions in their neonatal periods. These cases were divided into those who underwent primary stenting 11 patients or primary TAPVC repair 18 patients. Among 11 patients who underwent primary draining stenting, 7 patients underwent stenting in the vertical vein. There were 3 patients with infracardiac type and 1 with mixed type TAPVC who underwent primary stenting in the ductus venosus. One patient needed emergency stent removal with the TAPVC repair because of the stent migration. None of the variables of the patient's characteristics were significantly different, including birth weight, TAPVC type. Also, no difference of diagnosis or apival regurgitation. The mean follow-up was 41.3 months in a primary stenting group and 45.4 months in a primary TAPVC repair group. Primary stenting could delay the timing of the TAPVC repair. Kaplan-Meier analysis showed a better survival in the primary stenting compared with the primary TAPVC repair. Overall mortality of the stenting group is 36%, whereas 61% in the primary TAPVC repair group. 45.5% achieved Fontan completion for awaiting Fontan in the primary stenting group, whereas 33.3% reached the Fontan operation in the primary TAPVC repair group. Of the 4 patients who underwent stenting of the ductus venosus, 3 had liver damage. 2 to 3 days after TAPVC repair. AST and ALT level were elevated over 1000. Ultrasound showed blood flow from the liver through the portal vein to the ductus venosus, where the stent was applied. The patients were taken the catheterization laboratory immediately to embolize the stent, which improved the AST, ALT level immediately. And this CT shows the anatomic features of these patients. Blood from the portal vein can enter IVC without entering the liver through the ductus venosus stent. There are the following limitations. And this study was conducted retrospectively in the single center and consequently included a small number of the patients. To conclude, for neonates with obstructive TAPVC, right atrial isomerism, and functional single ventricle, our delayed strategy for TAPVC repair using primary ductus stenting can delay the timing and improve the survival compared with the conventional strategy. When TAPVC repair is performed after ductus venosus stenting, we should be aware of the potential liver damage and consider an early catheter intervention. Thank you very much for your attention.
Thank you, Dr. Kasahara, for a very interesting presentation. I think the series time span was 30 years. Is that correct?
Yes.
Right. How was the evolution over that 30 years? How was the mortality of the primary repair evolving?
So that we have that many cases of that heterotaxy syndrome and Fontan procedures, and especially for that the TAPVC repair is more cases about that. So TAPVC repair in the single ventricular physiology around that 80% to completion the Fontan. So no TAP pulmonary venous obstruction anyway. But especially for that combined with heterotaxy syndrome is a very severe condition about the TAPVC stenosis.
Okay, there's a question from Savikumar Savalingam, and I will read the question. How do you deal with the patients who will need a concomitant shunt in the neonatal period? Do they undergo a stent followed by a shunt, as many have branched pulmonary artery stenoses, wherein you will need to do a concomitant pulmonary artery reconstruction, especially in heterotaxy syndrome?
Okay, thank you very much, Shiva, and one of my friends in Shiva. That's one of that very important question about that, especially for heterotaxy syndrome. So pulmonary artery overflow or pulmonary artery low flow. I think that there's some concern about that pulmonary venous obstruction anyway. So concomitant to the BT shunt is that a little bit concerned, a little bit overflow is much better than any another single ventricle physiology one. So shunt usually to the branch pulmonary stenosis, I will do that shunt anyway.
Okay. There's a second question from Jose Antonio Cabrera Matienzo, and he asks, what is the recommended approach to the newborn with single ventricle pulmonary atresia and total pulmonary abnormal venous connection?
Yes, and thank you very much. So the case by case. So severe pulmonary venous obstruction caused by that vertical vein stenosis. That we ask to that the heart team and the cardiology do that stent in the vertical vein. And also, if that a very difficult situation about that the small vertical vein, we can do that TAPVC repair combined with the some shunt.
Okay. So in conclusion, you are still using stenting of the stenotic venous connection.
Yes, exactly.
Selected cases.
Exactly.
Right. Thank you very much. Very interesting.
Thank you very much.
We can go on with the next presentation.
The next speaker is David Kalfa. He's from New York in the US, and the topic is primary pulmonary vein stenosis, etiology, diagnosis, and management.
Hi, I'm Dr. David Kalfa. I'm a pediatric cardiac surgeon at Columbia University Medical Center. Thank you to the World University for Pediatric and Congenital Heart Surgery for inviting me to participate to this webinar. So it will be a brief talk about the primary pulmonary vein stenosis, about etiology, diagnosis, and management, a huge topic, difficult to squeeze in for a brief talk, but we will do it. The pulmonary vein stenosis can be categorized in either the primary or congenital or the post-repair following TAPVC repair or other type of repair, and we will focus here on the primary one. We know that it's a rare lesion. It's a serious disease with still a high morbidity and mortality rates, up to 50% within 5 years. There is a continuum in the severity, and we will discuss about that later. The etiology, unfortunately, the etiology is still poorly understood, right? We all know that there is a neo-intimal proliferation of cells inside the lumen of the pulmonary vein, but it seems like it is a multifactorial disease. A multifactorial disease where genetics seems to play a role, even if the most recent leakage study didn't show any disease-causing gene identified, but one locus associated with the disease. The disease was also associated with prematurity, necrotizing enterocolitis, and bronchopulmonary dysplasia, maybe through the VEGF pathway. And finally, the flow and the hemodynamics inside the vein play a role, with the role played by the shear stress and also potential external compression by other structures. From a histopathology standpoint, there is a continuum of severity from discrete to diffuse to a true atresia. Cato showed that the neo-intimal proliferation that I was talking about a few minutes ago is the proliferation of spindle-shaped cells resembling myofibroblasts, and there is also a lot of accumulation of extracellular matrix. Other studies show the potential role of the activation of tyrosine kinase receptors through the VEGF pathway, and also the activation of the TGF-beta pathway and the angiotensin 2. From a diagnosis standpoint, the echocardiography will be the first and the first line imaging modality, but it comes with a lot of limitations, which is the reason now the multimodality imaging is getting more and more importance to identify and assess, number one, the mechanism of the disease, of the obstruction, number two, the extension of the disease, and finally also help with the follow-up after treatment. I will not go into the details of the advantages and limitation of the different imaging modalities, but besides cath, now we have the CT scan, we have the MRI, and the lung perfusion scan that we need to take into account. We have developed, some PVR scores have been developed. So the first one is an echocardiography-based severity score developed by the group from Toronto, Nicolas Viola. And then a few years later, my group developed a multimodality imaging-based severity score, which has been useful based on the echo-based findings, the CT or MRI-based findings, and also the bilateral aspect of the disease or not. These two scores still need to be validated through prospective studies. Now let's talk about the treatment options. So the treatment options, there are a lot of options, which mean that none of them are really optimal, unfortunately. There are surgical options, catheter-based interventions, medical therapy, and unfortunately also transplantation and palliative care are also options to consider. As a surgeon, we'll focus on the surgical options, but I will briefly go through the catheter-based and medical therapy at the end. So most of us know here, of course, that the sutureless repair has been a significant change in our armamentarium for this disease. So before the sutureless era, there were like the non-sutureless or conventional repair, which included the direct anastomosis or the patch techniques with the living tissues or devitalized tissues or synthetic materials. But the results of these techniques, as you know, have been quite disappointing. What about the sutureless repair? So you know that the sutureless repair is based on the concept of creating an atriopericardial anastomosis to let the blood from the pulmonary veins drain into this cavity or neocavity to go then into the left atrium. So we can be more or less aggressive with the pulmonary veins tissue. We can do some incision or resection. It has been described by Lecourgaillet and Najm at the end of the 1990s. We avoid putting, this technique avoids putting sutures on the intima of the pulmonary veins, which decrease the intimal injury and also decrease the anatomical distortion at the veno-atrial junction. So initially, our community was quite actually excited about these results with early results that were promising. So for the series from Davenay and Azaki in 2006 and 2011 showed a low rate of death, but unfortunately, later results were actually quite disappointing. The series from Song, Charlagola, or Shim in 2013 to 2016 showed a significant amount of mortality, reoperation, and restenosis. We published in 2017 the first multi-centric study on primary pulmonary vein stenosis. I think at the very beginning, again, we are just talking about the primary pulmonary vein stenosis and on the secondary ones. So this study, mainly based on ECHSA European centers, but also included a few American centers, included 13 patients, 21 had a sutureless repair and 9 had a non-sutureless repair. You can see that the sutureless repair were the patients in this sutureless group was younger, smaller, and has a more severe disease compared to the non-sutureless repair. And we have to keep this in mind for the interpretation of the results. With more severe pulmonary hypertension, higher preoperative severity score, and more diffuse stenosis. Overall, the results are, not good, right? With 50% overall of recurrence and persistence of pulmonary vein stenosis, 40% of reoperation or mortality, and 30% of disease. And basically, we showed that, the postoperative pulmonary hypertension and the severity of the disease evaluated by this new severity score were independent prognostic factors, regardless of the surgical technique. And basically, these findings were then confirmed by two other more recent studies. A study coming from the Atlanta group with Dr. Asofi, published in 2020, 34 patients. This population had a less severe disease compared to the multicentric study that I just mentioned, with the median PPVS severity score about 3.5 only. Our patients were with a median severity score about 8.8, and with better outcomes, as you can see here, maybe related to the lower severity. And this study also confirmed the important role played by the extent of the disease, because you can see that the bilateral disease, the number of affected veins, and the PPVS severity score published by our group was significant risk factors for worse outcomes. And the most recent study from the group in China, from Dr. Shujun Lim from Fuwai Hospital, published in 2021, confirmed exactly the same findings, actually, with a larger series, this time 40 patients, again, a population with less severe disease compared to our series. And interestingly, they did actually less sutureless repair and more patch venoplasty. Better outcomes may be related to also the lower severity, with overall mortality reintervention and restenosis in 15, 12, and 25% of patients. And again, which confirm the important role played by the extent of the lesion with the bilateral involvement of the pulmonary vein disease. So overall, the surgical options are not optimal and actually are quite disappointing, and does not prevent the recurrence of pulmonary vein stenosis and, at the end of the day, sometimes the death of the patient. Let's go quickly through the catheter intervention. So overall, we have balloon angioplasty and stenting. And again, these techniques do not yield unsatisfactory results, mainly related to the high rate of PVS recurrence. So we use this strategy to optimize basically the result of the surgery, or also as a bridge to transplant. So very briefly, balloon angioplasty versus a cutting balloon angioplasty. Overall, the freedom from reintervention in the entire cohort was only 15% at 1 year. In terms of stenting, same thing, the freedom from diagnosis from in-stent restenosis was 30% at 1 year only. The stents with a luminal diameter of less than 7 mm was associated with a shorter freedom to reintervention. And we have new technologies, new stent technologies now, drug-eluting stent and bioabsorbable stents, but we don't have really a follow-up on these technologies. Finally, one word on the medical therapies. The symptomatic treatment has its place, of course. There are also some experimental therapies, which includes, just as an example, the methotrexate, the vinblastine, the Glivec, which is a tyrosine kinase inhibitor, the Avastin, which is a VEGF inhibitor, and more recently the losartan. And we are still waiting for the result for the losartan studies. But overall, none of them has proven to slow the progress of the disease yet, unfortunately. So to conclude, right, the outcomes and the way that we are able to treat these patients is still unsatisfactory and disappointing. Very unfortunately, this remains a very severe disease, and there are multiple gaps in knowledge that we need to fill, right? What are the diagnostic criteria? What are the disease phenotypes to try to adapt the treatment strategy to different types of patients and different types of disease? What are the best practices? And we definitely need also to understand much better the physiopathology of this terrible disease with fundamental research and multidisciplinary and multi-institution collaboration, such as the PVS network. Thank you very much for your attention, and I'm happy to answer any question during the Q&A session.
Well, thank you, David, for a wonderful overview of a very disappointing disease. It's totally different from the previous part of this webinar, and one wonders if this is a surgical disease at all, because one wonders what would happen if we would not operate. And also for transplantation, I see a lot of problems, because are you talking about a combined heart-lung transplantation? Because these pulmonary veins are both attached to the lung and the heart.
Yes, absolutely. So I completely agree. I'm not sure if it's really a surgical disease, but I think that at least in some patients, the surgery can try to improve things or delay things or try to really, sometimes treat the patients through multiple surgeries and surgical interventions. To answer to your question about a transplant, yeah, that would be a heart-lung transplant, right? So which comes with a potential, high risk and high morbidity. Also, from the immunosuppression, we know that lung transplant in children are quite risky compared to what we know very well in the world of heart transplant. So one more time, this, even if you put aside the issue of the lack of organs, this option is definitely not a cure. You replace the disease by another disease, unfortunately. So overall, that's not the panacea.
So am I exaggerating if I call this palliative surgery?
Absolutely not. This is a palliative surgery. I agree with you, Tjark.
There's a question from Hani Najm. Could you do sutureless repair beyond the pericardial reflection?
That's a very interesting question. Thank you. I believe so, yes, because I think that you can go beyond the pericardial reflection, but not beyond the actual pleura, right? What you do not want to go through is the pleura to avoid significant bleeding in the chest. But you can go definitely beyond the pericardial reflection, right? As far as you can, but not going through the pleura. And even if you go through the pleura, you can fix it, right? Of course, by putting the pericardium away and add some very, very, very superficial stitches of 7-oproline or 8-oproline through the chest and not through the mediastinum, right? Which is a reason why we should never, never hesitate to be quite aggressive in terms of how to treat this lesion, surgically speaking.
I agree. And there's a question from Sultan Al-Harti. And his question is, what is the recommended intervention if only one pulmonary vein is stenotic?
Another very good question. There is no clear answer to this question based on the literature. I think that you have different tools to try to assess what are the benefits and the risk of the surgery, basically, right? So it's all about the balance between benefits and risks. Knowing more and having more information about the upstream veins that Dr. Caldarone was mentioning a few minutes ago is very important. Using the multimodality imaging strategy is actually also very important. Following this patient is actually, I think, primordial to try to assess the evolution rate. And then, of course, if the patient is symptomatic, you need to go, but also see how the patient is doing clinically. The PVS score that I was mentioning might be helpful. One more time, these PVS scores have not been validated. They seem to be helpful in the management, but this has not been proven yet really in prospective studies.
Thank you, David, for a very nice presentation on an extremely difficult disease that is actually quite distinct from total abnormal connection.
Absolutely, thank you.
Thank you very much. We can go on with the next presentation.
It's a pleasure to welcome Parvathi Iyer. She's from Delhi in India and will address us in this final talk on perioperative ICU management, including late presentations. Thank you.
Good day to you all. I thank the World University for giving me this opportunity to speak on total anomalous pulmonary venous connection, perioperative intensive care management, including late presentation. I have no disclosures to add. Surgical outcomes for TAPVC, particularly obstructed veins, still carry considerable early mortality. The usual cause of death reported is severe pulmonary hypertension. Late presentation or presentation in cardiovascular collapse, as occurs in our part of the world, is expected to be associated with far worse outcomes. This is outcome data from the United Kingdom showing mortality, ECMO utilization, and a pulmonary hypertensive crisis of nearly 10%. So the outline of my talk is going to include late presentation, its implications, physiological effects of rerouting of the pulmonary veins, anticipated postoperative problems, our approach to perioperative management, and current feasible outcomes. So what is late presenting TAPVC? That which presents late in the natural history with no specific age as being cut off. Anatomically, there is significant pulmonary venous obstruction on echocardiogram, either at the PFO or the vertical vein. A number of them present in cardiovascular collapse or in a very sick state. This slide illustrates the two common sites of obstruction, the vertical vein as well as the foramen ovale. And this slide illustrates the radiological differences between the two kinds of obstruction. Obstruction at the common vein is invariable in the intracardiac variety, less so in the cardiac. It's most often seen in neonates and younger infants. The pulmonary artery hypertension is secondary to the pulmonary venous hypertension. Many of them present with respiratory distress, and predominantly postoperative lung issues occur. On the other hand, obstruction at the foramen ovale is more common with the cardiac and the supracardiac variety, is seen in older infants and late presenters, like in our part of the world. Many of them have heart failure or cardiogenic shock. There's cardiomegaly on the X-ray with relatively clear lung fields. The right side of the heart is volume loaded with an underfilled left heart. Many of these infants need inotropes for stabilization, especially if they present late, and postoperatively cardiac issues predominate. This slide illustrates the restrictive ASD, which is seen in late presentation, and the unobstructed vertical vein. So what are the implications of long-standing pulmonary venous obstruction? There's gradual distension of the right-sided chambers with an underfilled, non-compliant left heart. And these alterations are far more profound the longer standing the PVO is. Thus, the hemodynamic effects of TAPVC rerouting includes offloading of the distended right heart, giving rise to a low central venous pressure. The offloading occurs into a non-compliant left ventricle, giving rise to a series of events including acute LV dilatation, septal dysfunction, elevated left atrial pressure, pulmonary venous congestion, pulmonary venous hypertension, and a pulmonary hypertensive crisis. Thus, there is resolution of tricuspid regurgitation with often onset of neomitral regurgitation. And all of this forms the basis of our management, which is a philosophy of postoperative left atrial pressure monitoring and postoperative afterload reduction. This is a schematic diagram which shows the ventricular load reversal and the acute LV dilatation following rerouting of the TAPVC. And the same thing is illustrated in this echocardiogram showing the dilated left ventricle postoperatively. Thus, the anticipated postoperative problems, which are greatly exaggerated the later the neonate presents, include the non-compliant left atrium causes surges in left atrial pressure, giving rise to left ventricular dysfunction, secondary pulmonary hypertension, and low cardiac output state. The surges in left atrial pressure also causes hemorrhagic stiff lung, significant endotracheal bleeding, and is a cause of acute lung injury or ARDS. Thus, the therapeutic approach that we recommend is highly preemptive and rational, and involves minimizing triggers of pulmonary hypertension, an aggressive lung recruitment strategy to reduce the pulmonary hypertension, and afterload reduction of the non-compliant left ventricle. Thus, preoperative stabilization involves supporting the right ventricle, and if the infant is transferred on the ventilator, we support them with dobutamine. If they're not ventilated and they're tachypneic, they need conservative management with oxygen, gentle sedation, restricted fluids before proceeding for early or emergency surgery, the resuscitation going on simultaneously. Perioperative strategies are of paramount importance and includes very careful weaning from cardiopulmonary bypass following a quick and accurate repair with a focus on minimizing cross-clamp times. We recommend a primary sutureless technique for diffusely stenosed veins. We monitor left atrial pressure and strive to keep them below 10 millimeters. We accept low blood pressures as long as the heart is contracting well. And in select cases, the sternal closure is deferred when the hemodynamics are unstable with very high left atrial pressures, or if the lungs are hemorrhagic and swollen. An intraoperative PD catheter is invariably cited. Other intraoperative strategies include methods to minimize CPB-mediated injury and include prophylactic intraoperative or combined steroids, ultrafiltration, and we use phenoxybenzimine in the initial cases. Postoperative strategies are highly preemptive and are based on methods to avoid surges in left atrial pressure by fluid restriction, avoiding fluid boluses, especially large boluses, use of peritoneal dialysis early on, and an aggressive afterload reduction strategy involving milrinone or levosimendan. Our main mantra is to accept a low blood pressure if there is no acidosis and if the lactates are normal. Standard and inexpensive modalities are used to address hypotension and pulmonary hypertension in the form of calcium infusion, physiological dose of steroids. We recommend a high PEEP ventilation to recruit the lungs, diminish the pulmonary vascular resistance, and enhance cardiac output. Again, the mantra is to attempt to wean ventilation only when the left atrial pressure is well under 10 millimeters. Two big pitfalls which need to be avoided are avoid administering large fluid boluses into a non-roomy, non-compliant left atrium, and avoid ventilatory weaning when the left atrial pressure is high, since this can lead to cardiovascular collapse. Ventilation, we attempt to ventilate in a manner so that the goal of ventilation is to keep the lungs at functional residual capacity, because it is at FRC that we get the lowest pulmonary vascular resistance. This is an illustrative case of a 2-month-old baby, growth reduced, who presented late with obstructed mixed TAPVC with RV dysfunction and a small non-compliant left ventricle with significant lactic acidosis. The infant proceeded for early surgery, and the postoperative course shows that the blood pressures were as low as the left atrial pressures, which were in the 20s. So the blood pressures and the left atrial pressures were almost similar, and gradually the blood pressures improved and the left atrial pressures resolved. How did we manage this? The labile left atrial pressure and the mean blood pressure were addressed by norepinephrine, physiological steroids, and thyroxine, and we ventilated for 70 hours nearly. The total vasoactive inotrope score was 23 and involved dobutamine, milrinone, and norepinephrine. This is the baby just prior to discharge with a length of stay of 12 days. The 30-day mortality over a 2-decade period is in the range of 3%, and the main causes of death were really due to severe multi-resistant sepsis, most of which was pre-existing. We had 23 instances of severe pulmonary hypertension, and there were no deaths due to pulmonary hypertensive crisis. A more closer analysis of the first 300 cases, that is till 2018, showed that the majority presented at an age older than 1 month of age, with under 20% presenting in the neonatal period. Majority was supracardiac. A third of them needed preoperative stabilization with ventilation and inotropes, and 4% needed preoperative cardiopulmonary resuscitation. There was significant obstruction present in half the cases, with majority being at the PFO level. The postoperative course of these infants shows that 80% of them had some degree of low cardiac output state, and the median vasoactive inotrope score was 13. Postoperative CPR was needed in 19 out of the 308. The point to note is that no patient required either inhaled nitric oxide or mechanical support. This slide illustrates the postoperative elevated left atrial pressures. We can see that more than 80% of them had elevated LA pressures greater than 10, and this resolved and improved by the 4th to 5th postoperative day. This slide illustrates a published series of outcomes of TAPVC, and we can see that this is our series down here, that we have fairly acceptable outcomes despite most of our infants presenting late. So thus, to conclude, speedy and accurate surgery is most important for good outcomes in TAPVC. Early mortality following surgery for TAPVC, despite late presentation, can be substantially minimized by a strategy which focuses on tracking ventricular function and lung recruitment rather than focusing only on pulmonary artery pressures. Nitric oxide, in our opinion, is not a panacea, and mechanical support in most cases may be avoidable. Thank you for your time and attention.
Thank you very much, Dr. Iyer, for a very stimulating presentation. Very interesting. I used to use a lot of left atrial pressure lines a long time ago, but I'm one of the oldest surgeons present in this webinar, I think. But my question to you is, first, do you use left atrial pressure lines in all cases or on indication? And if so, what is the indication?
We use left atrial pressure lines in all our patients of TAPVC. The only cases where the lines were not there were just a handful of them where the lines fell out actually or became non-functional after transfer to the intensive care unit.
And what are the highest left atrial pressures that you have met in this group of patients?
One of the highest left atrial pressures were in the high 20s. And that was actually quite alarming when you actually see that kind of left atrial pressure. You're not inclined at all to wean ventilation. And what bothers us is that if you don't have a left atrial pressure line, you are quite oblivious to this fact that the left atrial pressure may actually be that elevated, and you might just wean faster, and the child may have a cardiovascular collapse, and we may find it very difficult to resuscitate this infant then.
There are lots of questions. I can hardly it's difficult to read it. But the first one is from Jose Antonio Cabrera Matienzo again. In late presentation case of TP-AVR with restrictive ASD, is there a role for atrial septostomy trying to increase the left atrial and left ventricular volume and diminish the possibility for pulmonary hypertensive crisis?
We think that there is such a role only if facilities for surgery is not available, or if the surgeon is not available, basically as a temporizing or as a bailout procedure. So we just prefer to go ahead and operate on these infants, you know, as soon as the baby is reasonably stable and the OR is available.
Okay, and then there's a question from Vital Kumar Betigeri, and he asks, what were the predictors of high left atrial pressure in your group?
The only thing that predicted the elevated left atrial pressures were, in some instances, the echocardiography was really worrisome, where you could see that the left ventricle appeared really small, and the left atrium also applied nearly hyperplastic and non-compliant. So we really had significant concerns about such infants, but we were ready to manage them in the way that I talked about.
Okay, and here's a question from Carlos Trocones. He asks, leaving ASD open or fenestrated will help those cases with low left ventricular size, or what is your opinion on that?
We don't believe so, and we really haven't ever left any TAPVC with a PFO open. Okay. I mean, I think all that it would do is cause a lot of cyanosis and complicate the picture. So usually the ASD is closed off.
Okay. There's one last question from Miguel Angel Arizapana. And the question is, in patients with univentricular physiology and non-obstructive total pulmonary anomalous drainage, who will undergo BT shunts? Do you consider deferring the correction of drainage in the neonatal stage due to high mortality? How old could we correct it?
We really haven't encountered this sort of a scenario because in our part of the world, most such infants frankly don't reach us. So we've not had that conundrum to deal with.
Okay, well, thank you very much. this is, we've reached the end of this webinar. And as this is the last presentation, thank you very much. And we'll have the concluding remarks.
Are there any questions? It's Christopher Chervankov for Christopher Baird, perhaps, because he didn't get a chance to have questions asked to him. One question I have is, how do we, can you guys hear me?
Yes.
One question I have is, how do we differentiate true left ventricular hypoplasia from a left ventricle that is basically compressed by the hypertensive right ventricle? Perhaps the Norman Silverman or Dr. Alhabshan?
Sorry, can you repeat the question for me, please, Christo?
How do we differentiate the cases of true hypoplastic left ventricle from a left ventricle that appears small because it is compressed by the hypertensive right ventricle?
Yeah, I think in total veins, we've done a series of patients and published that, in fact, to show that immediately on removing the right ventricular volume load, the ventricle actually improves. So the issue is that it improves more even than what you'd expect from the echocardiogram, because the model that we used didn't take into account an increase in ventricular length. So in fact, the ventricle is not a cast, but it's a dynamic thing. And when you impose different loads on it, it changes. In my experience with echocardiography, immediately on taking a simple total veins, the RV-LV relationship changes immediately. If you're talking about something with an AV septal defect and right isomerism, for example, I think that's a whole different kettle of fish. There, the ventricle is small, it is functionally small, and there are really obviously great problems in that. But certainly, I think for the general issue, when you're dealing with a regular total anomalous pulmonary venous return, immediately on the post-bypass echocardiogram, the ventricles have changed their morphology and increased both in their length, in their width, and especially the fact that the ventricular septum now bulges the other way markedly improves the volume of the ventricle. So that's the general rule.
If you allow me to add to that, the left ventricle, which is compressed, usually has a normal length that it reaches the apex. Usually it has a normal base with a mitral valve Z-score of -2 or above, and it has a normal LVOT diameter that could be slightly small, but it's like -2 and above. So these are the elements where we can differentiate between hypoplasia and the small compressed left.
Thank you.
Okay, thank you very much. I want to thank all our esteemed colleagues for sharing this with us today, and to all of you for joining us. I want to remind everyone that this webinar was recorded and will be available in the World University website. This has been the ninth in our series of monthly webinars in congenital heart surgery from the World University, and the next webinar will be on July 17, covering the topic atrioventricular septal defect. Thank you, and have a great weekend. Thank you.